Yeah, thank you for having me. I'm Dustin Sulak. I'll just give a very brief background. I'm an osteopathic general practitioner. I left residency after 1 year and went into practice. I thought I'd be doing mostly OMT, which is still about half of my practice, but that was in 2009 when Maine passed a medical cannabis law, and I was pretty much the only doc in the state willing to sign off on those certifications. So cannabis very quickly took over my career and my practice, which I'm thankful for. It had been an interest of mine since I was 15, and I just never knew that it would be such a big part of it. And cannabis has been wonderful. Like I think a lot of the modalities that you all work with, it can, but maybe especially cannabis because of how it interacts with the endocannabinoid system. It just made me a magnet for refractory conditions from all over every different subspecialty of medicine, which is kind of like the dream of the osteopath and the generalist. So it's been wonderful. And then about 6 years ago, based on the prompting of one of my mentors, I began experimenting with prescribing low doses of ketamine to my patients to use in an outpatient setting, and also to digging into the literature, which I'm going to share with you tonight to support that practice. And what I found is that ketamine is an extraordinarily safe and versatile and effective tool, and in many ways similar to cannabis, different in a lot of ways because it's a single molecule instead of an herbal compound. But in terms of its versatility for treating mental and physical health conditions, for working via novel mechanisms of action in situations where other pharmacotherapies have failed, and for kind of the mind, body, spirit effect of this treatment. A lot of what I learned about ketamine, about cannabis, I've been able to apply to ketamine successfully, and I'm happy to share that with you all tonight. I also just want to put in a little plug if any of you are interested in a reference about cannabis. This is my book, came out in 2021. It's still extremely relevant. It's very easy to use. You don't have to be an expert. If you want to know how to treat a certain condition with cannabis, you can open right to it and get the cliff notes on it. All right, well, let's go into the slides. So we'll talk a little bit about ketamine's history and pharmacology. And then for the purpose of this lecture, I'm going to focus on the low dose oral and oral mucosal applications of ketamine. It works via multiple routes of administration and many different dosing formats. And if we have time at the end and you guys want to hear more about what I'm doing with higher doses in the office, we can talk about that as well. So the history of ketamine, first identified in 1962. It's a derivative of PCP, and it was studied in 1964 and then approved in 1970. Even back then in the mid-1970s, there were some papers about ketamine having some analgesic and antidepressant effects in animal models, and even a little human evidence of that. But it was just such a good anesthetic that's where it ended up getting approved and kind of remaining in medicine, with some of these other benefits of ketamine staying pretty quiet for a long time. It's distinct from other anesthetics because it doesn't suppress cardiorespiratory function. So it's got a lot of versatility for use in the field. It can be used in the ER if you're not an anesthesiologist. It's pretty safe to use there. It can be used in the battlefield. It's not going to drop blood pressure and make it hard for someone to get off the field. It's used frequently in pediatrics and in veterinary medicine in cases where it's hard to intubate the patient. So really versatile as an anesthetic. And then what else? So what happened was in the 2000s and 2010s, there were more and more evidence gathering, and I'll show you some of it, that little bits in the literature here and there that ketamine was actually having these profound antidepressant effects. And that led up to more research until 2019, when S-ketamine, which is just one of the two enantiomers of ketamine, S-ketamine was approved as an antidepressant for treatment-resistant patients. And that's a nasal spray that has to be administered under physician supervision. Now that was approved as S-ketamine because that's what you could patent. Racemic ketamine was old and generic and there was no money in it. As all of you know, the likelihood of new FDA indication for a generic, cheap, effective, safe drug is almost zero. But here ketamine has been in the compounding pharmacy for all of these decades. And then finally this new drug in 2019 came out. And really the racemic ketamine, the RS combination, is probably more effective than just the S enantiomer that got approved in 2019. And that goes by the brand name Spravato. So here's an example of one of these papers that caught some attention. This was the effective intravenous ketamine in suicidal ideation of emergency department patients. And, when someone comes into the ED trying to harm themselves, they're typically given something to tranquilize them. And as you can imagine, there's a lot of options of what to use. What this study showed was that not only did the suicidal ideation scale and the depression scales improve rapidly within, the course of 2 hours, but also that effect persisted for 10 days. And this was after a single administration in the ER. So, and this was a follow-up because there were some case reports that were, not expected for someone to have this profound, long-lasting benefit from ketamine after a single dose. But that's what happened in these. 10 days later, 85% of them had no suicidal ideation. So, of course, it had been increasingly researched and clinically applied for quite a few conditions, not just depression, but alcoholism, substance misuse, PTSD, OCD, other psychiatric diagnoses, and chronic pain. There's some similarities, as I mentioned, with cannabis. Both have a wide, safe, and effective dosing range, really quite wide. I mean, some of the doses I'm using with ketamine are much lower than I think a lot of people would expect, and same with cannabis. They have psychoactive effects that can be therapeutic, so it's not just like somnolence or something that's impairing, but actually in the right setting, these psychoactive effects can be incredibly therapeutic and sometimes transformational. They both work via multiple routes of administration. For ketamine, it's oral, oral mucosal, intranasal, rectal, topical, intramuscular, subcutaneous. Pretty much every way you could get a drug into someone, ketamine goes in that way effectively. Impressive safety profile that's well characterized for both of them. Very high response rate, especially among refractory patients. And really these versatile benefits in mental, behavioral, and somatic symptoms.
Hey, Dustin, real quick. Do you want us to ask you questions as time goes on, or do you want to wait till the end?
Yeah, I'm good with, it's a small group. I'm good with asking questions as time goes on. And if it's something that I'm planning to talk about later, I'll just say we'll save that for later.
Okay. Piss test. Drivers and federal government, veterans, employees like that. Is there a test for ketamine? Just like cannabis?
There is. It's not typically included in your average urine drug screen, but it can be screened for. And it's a Schedule III drug. So if you have a prescription for it, then you pass the test. Just like if you had a prescription for Valium and it came out in your urine, but you still passed the test. I'm actually curious. Let me ask a question of the crew. Has anyone here prescribed ketamine? I'm curious how many of the listeners have actually prescribed ketamine to a patient before. I saw one little thumb go up. Anybody else? 2? Okay.
I've made it for hundreds of doctors and thousands of patients ever since I patented its topical application for neuropathic pain in '95.
Holy shit, I didn't know that about you, Kent. That's amazing. So what happened with that patent? I mean, like, I prescribe it for topical neuropathic pain, and nobody's ever asked me to pay you for it.
And then try to get out of it, circumvent the patent. So it ended up in an appellate appeal for fraud, but those attorneys that drug companies have, They can look straight at you and lie and make everyone believe it's truth. So not a good outcome for a lot of inventors.
Got it. Well, that was clearly a good idea. I've used it topically for neuropathic pain, and it works. It's definitely
Yeah,
an
it's
effective
fascinating how well it works.
All right, so let's talk about how it works, which is, I'm sure, in part still a mystery. Ketamine is an NMDA receptor antagonist, so this is a glutamate receptor. But like so many weird things in G protein coupled receptor land, at certain doses, the antagonist can actually enhance the transmission of these signals. So there's something special about ketamine. It's not just your average NMDA antagonist. An example of that is memantine, which is also an NMDA antagonist, and that doesn't do any of the stuff that ketamine does. There's also a primary metabolite called norketamine or hydroxynorketamine that it's metabolized to, which is really interesting. We'll be talking about that more tonight because with the first pass metabolism of taking ketamine orally, as you'll see, you're going to get a bunch of this, which is different in pharmacology than the original molecule. It's a much weaker antagonist, but it seems to be doing some important things. So in terms of the antidepressant effects of ketamine, I mean, they're really quite complex, but I just use this very simplified diagram, which is basically trying to say this is not just a glutaminergic effect. This ends up impacting the release of all these neurotransmitters and neurotrophic factors. And the BDNF is kind of the one that's has the most emphasis now in terms of the mechanisms of the antidepressant effects, but it's really all of these. It's a whole brain shift. So I don't want you to get too focused on targets and mechanisms of action, because what happens downstream after this NMDA inhibition is really unique and profound. But what you can measure in animals is an enhanced synaptic strength. This is a neuroplastic effect that results in building new connections in the brain and perhaps in the peripheral nervous system, that results in less anhedonia, less despair, and less suicidal ideation. Now, getting a little bit more in depth here, we can look and I'm not going to dwell on all of these steps, just point out a few. The thought of how ketamine as an antagonist will potentiate glutamate signaling is that it's most likely working more so on the presynaptic NMDA receptor instead of the postsynaptic one. And by inhibiting the presynaptic receptor, it's kind of interrupting a glutamate negative feedback signal, which allows for more glutamate signaling postsynaptically, which is what you're seeing here with these little red dots. And so you have, sorry, was that a comment? Oh no, okay, we'll continue. So so what you can see happening here is that this is going to eventually trigger the release of the neurotrophic factor BDNF, which then acts, either on that cell in an autocrine or in a paracrine manner to the surrounding cells in the nervous system, and goes through a process which you can see here actually ends up stimulating mTOR. There can be some, synergistic effects with lithium. You can see how lithium, and this has been measured in animal models, ketamine plus lithium seems to be a good combo for potentiating effects. You can see how lithium kind of gets into this process here. And in the end, you're looking at enhanced synaptogenesis and the antidepressant effects. But again, this is an oversimplification. I just wanted to give you some of the mechanisms here. Looking at a whole paper here from 2014 on all of its non-NMDA mediated effects. So you can see that there's quite a few. And so we're not going to be covering all of this, but this is just, whether you call it a dirty drug or pleiotropic mechanisms of action, there's a lot going on here beyond just the BDNF and the mTOR mechanisms. So what's thought is that the prolonged antidepressant effects probably arise from these downstream post-drug effects such as activity-induced increase in structural synaptic connectivity. And what this means is that it's not the antidepressant effects of ketamine, which you saw from that paper out of the emergency room, is not dependent on having ketamine or its metabolites in the body. The drug is metabolized and excreted, yet the antidepressant effects persist, which likely has to do with these long-term impacts on the way the brain is connecting and working. The analgesic effects are probably a combination of opioid sensitization and aminergic antinociception. So the aminergic systems are the serotonergic, the dopaminergic, and the noradrenergic. Oh yeah, and the histaminergic. So it's like all of those aminergic systems can play a role in suppressing pain signaling or the interpretation of nociception as pain. And it's probably working via all of them. And then its ability to inhibit neuropathic pain is probably a combination of its immediate receptor-mediated action and this initiation of longer-lasting cell signaling cascades, which is what we see. You know, like when I'm talking to somebody with chronic pain, especially, you know, I'll think of ketamine, especially if they've been using cannabis effectively and it's not enough for them. And especially if I feel like they've had some sensitization to the pain, a central or a peripheral sensitization. And the way I explain it to them, and this is based on what my patients have told me, is that they take the ketamine and they can get a period of time that's completely pain-free, which for a lot of people that have been in severe pain for a long time is pretty profound. And then after that pain-free time, of course, the pain comes back, but they have a somewhat different relationship with the pain. And that shift in how they experience the pain will persist for several days or weeks. Sometimes the old patterns of pain, you know, it's not, of course, it's not just feeling the pain, right? It's all the associated reaction to the pain, the assessment that this is an aversive experience, the anxiety about having more pain, the, you know, pain behaviors and the social isolation, all that kind of wrapped into a ball. Well, that can come back in, but it's so interesting that just having this break from the pain followed by this different relationship with it is kind of what most people are talking about, at least in the moderate dose range. So pharmacokinetics, this would be bioavailability, intramuscular and subcutaneous, you know, this is a study from 2022, estimated about, and it was a review article, estimated about 64%, intranasal 25 to 35%, sublingual or oral mucosal up to 25, so similar to intranasal. Swallowing it, you know, enteral absorption even lower, about 16.5%. And of course, if you take it sublingually or intranasally, there's a good chance you're going to swallow some of that, so you get a little bit of both. So this is an interesting study from 1981 that showed that it compared the analgesic doses of intramuscular ketamine and oral ketamine. And what they found was that the plasma level of ketamine associated with analgesia, so if you were going to give someone an intramuscular injection of ketamine, you'd have to get their plasma level up to about 150 nanograms per milliliter to have an analgesic effect. But if you give it to them orally, you only need to get their plasma level up to 40 nanograms per milliliter of ketamine. So why would that be? You know, why would oral require less ketamine? And of course, the answer that you can see on the screen here has to do with this metabolite, the norketamine. And we'll see a little bit more on that on the subsequent slides. So the intramuscular peaked at 22 minutes, oral peaked at 30 minutes, so not a big difference there. The pharmacokinetics of oral are a little slower, but not that slow. And so what you can see here from this paper on the top, we're looking at intramuscular administration of 0.5 milligrams per kilogram. And you can see that the level of ketamine goes way up and then comes down. And of course, the level of norketamine, the metabolite, increases a little more gradually, never gets as high. But if you look at the oral dosing, you see the opposite. You see the norketamine, especially if it's swallowed, because there's first pass metabolism here. So you see the norketamine going way up to the 200 nanogram level, and of course ketamine staying much lower. So there's something special about that metabolite. In terms of drug interactions, ketamine is metabolized. Well, actually, what do I say about the metabolite? It has analgesic properties, it has antidepressant properties, and it's a lot less psychoactive. So,
Do you have with this graph right here? Do you have a high blood pressure rate? Because that's the ketamine specialist that I'm talking to right now. That's what they're worried about for the in-home use.
Yeah, I mean, we'll talk about that. That's coming,
Okay.
but
Excellent.
it's not a big concern. So, drug interactions in terms of CYP, we've got 2B6 and 3A4. Of course, the 3A4 is like the one that all the drugs interact with, including grapefruit and all that stuff. So, yeah, it could have an impact on other medications. And that, of course, would be more pronounced at higher doses of ketamine, and certainly more pronounced if you were taking it orally at the same time as these other 3A4 medications. In terms of this 2B6, though, there's a lot of, it's one of these that has a lot of genetic variability. And so there's going to be some individuals that process ketamine fast and some that process it slow. And I guess we could say that about just about any drug, but we might see variability a little bit more in ketamine. These would be pharmacodynamic interactions. So it seems like the antidepressant actions are dampened by benzodiazepines taken concurrently. It's definitely not abolished, though. People on benzos can do well with ketamine. Same thing with atypical antipsychotics. I see maybe a blunted response to the ketamine, but certainly they're compatible. Lamotrigine is an interesting one because it may reduce, concurrent lamotrigine may reduce the risk of ketamine-induced adverse effects, which is how this paper put it. But really what you see is that lamotrigine makes it harder to feel the ketamine, which is your target in some situations. You want people to feel it. When people are on lamotrigine, they usually require higher doses of ketamine. And interestingly, someone who's had a beneficial response to lamotrigine is more likely to have a beneficial response to ketamine. So those two have quite a few interactions, definitely no contraindications, just some things to know about. And then the beautiful thing about ketamine is that most conventional antidepressants can be used concurrently. So you don't have to stop their SSRIs or their tricyclics or whatever else they're doing. You can start ketamine and taper those others later. What about combining ketamine and cannabis? A little information from the literature on this. In one human study, CBD was shown to increase the psychomotor activation produced by ketamine. So when you give someone enough ketamine to have a psychedelic-like experience, they tend, not always, but they'll sometimes have some psychomotor activity, like they're laying on the table dancing kind of thing. Like, sometimes their limbs are moving or their bodies are shaking. It looks like some kind of a healing process. They are sometimes aware and sometimes not aware of the movements that they're making. And CBD can increase that psychomotor activity and also reduce some of the ketamine-induced depersonalization in that one study. Another study from 2018 found that ketamine's anti-nociception depended at least in part on the endocannabinoid system, anandamide release, and CB1 receptor activation, at least in inflammatory conditions. And then anecdotally, 95% of my patients use cannabis. We've now treated over 500 patients with ketamine in my practice. So I've had a few people talk to me about what it's like to combine cannabis and ketamine. And most of them think that there's a potentiating effect, that the cannabis enhances the benefits of the ketamine. I make sure that most people try their ketamine alone first, and as we titrate to the effective dose, and then at a follow-up visit, I'll encourage them to try at one point using a little inhaled cannabis just before using the ketamine. And most of them come back and say, wow, that made a big difference. I like it even better. It seemed to work better and last longer. So a lot of people in the ketamine world have no clue about what I'm about to show you here. There's quite a bit of good, small studies, but good evidence base around these low doses and the oral and oral mucosal routes of administration. For a few years before I started using ketamine, in my mind, I was watching it. I thought, okay, I really want to do ketamine for my patients. I must get an infusion center? Do I have to hire a nurse anesthetist? Like, there were all these like hurdles and barriers until I finally listened to the person who had given me, some of the best advice of my career and just start prescribing some troches with ketamine. And I was really impressed. So you're about to see some things that you may not believe. This was a study from 2013 with 26 outpatients with refractory unipolar or bipolar depression. A lot of people think ketamine's contraindicated in bipolar disorder. It is not. I wouldn't give it to someone during a manic episode, but it can certainly be used during the depressive episodes. This study used 10 milligrams of ketamine. This is a very low dose. It was just 0.1 mLs of the injection solution, held for 5 minutes and then swallowed, and then repeated every 2 to 3 days or once weekly. So very low dose with infrequent use. And here you can see on the right is the rapid improvement in mood in most of the patients. This chart only includes 11 of the 26 patients, but you can see that an hour and a half later, their mood scores are doubling or tripling or even quadrupling. I mean, it works fast. This 10 milligrams, they're not just reporting better mood because they're tripping or they're high. I promise you, 10 milligrams is barely noticeable for most people, or not noticeable for most people, but ask them an hour and a half later how they're feeling and their mood's going to be better. 2 bipolar patients reported agitation for a few hours. So there were 2 out of these 26 that were sensitive to this 10 milligram dose. Mild lightheadedness was a common but transient side effect, subsiding typically in less than 30 minutes and typically most pronounced after the first dose. So 10 is a very safe starting place. And in my practice right now, I start most people at 20, actually. So here's, so some of the other results. 20 out of the 26, so 77% achieved remission or a clear response for depression, mood, instability, cognitive impairment, and poor sleep. The remission remained in many of the patients or some of the patients after stopping ketamine. 3 had a moderate or partial response and 3 failed to respond. And you're going to see this number in a lot of these low dose studies. It's somewhere between like the 75 and 85% range that you'll see a substantial response. And I'd say that's very high considering these are treatment resistant patients. Some patients are the relative spontaneously used adjectives such as sensational, amazing, incredible. I am back to life again. The best night of sleep in years. 10 milligrams of ketamine, I mean, tiny doses. Here's some of the cases. I just included a few of these. I don't want to belabor it, but I think it's important to look at what this tiny dose does. So here's, this first case, a 26-year-old male who had been in a depressive episode for 3 months, had 5 previous episodes. Look at all these drugs that this person has tried. I'm not going to read them, but my God. He was given 10 milligrams of ketamine every 7 days over the course of 20 weeks. Clear reduction of depressive symptoms, irritability and excessive food intake, more rational decision-making, improved cognition, and mood stability remains well after stopping ketamine. How about this one? A 34-year-old female in a depressive episode for at least 3 months was also had tried many medications previously. 1 dose of ketamine, 10 milligrams orally, sustained remission after single dose with recovery of energy, vigor, emotional regulation, and adequate decision-making. Another 50-year-old male with bipolar, panic attacks, previous cocaine dependence, and chronic insomnia. A lot of drugs tried. This was 5 doses every 3 days, so a 15-day treatment. Rapid but moderate response with partial improvement in energy, negative thinking, mood instability, and cognitive dysfunction. Mild improvement in insomnia. My question is, what would have happened if we titrated this patient? He was clearly a responder, but remained at 10 milligrams and didn't go any higher. Here we've got a major depressive disorder, a 36-year-old female, given every 3 days, 12 doses. So, 36-day trial. I mean, this is like nothing. Rapid and sustained increase in energy, motivation, resilience, vigor, and pleasure. And it goes on. I'm just giving you a sample of these, of what these tiny doses of ketamine can do. Here's another study from 2018. This was not the best study design, in my opinion, but decent. 81 people with major depressive disorder. They were given sertraline at 25 milligrams and then titrated rapidly to 150 milligrams. And then with the sertraline, they were given either 50 milligrams of ketamine in a capsule or a placebo.
Dustin, can I just break in for 1 second?
Please.
Apparently your slide is tiny at the bottom, but if anybody clicks on it, you can maximize it.
Okay, thanks.
Okay.
You guys, yeah. Thank you, Bill. Let me know if I need to do anything different on my end, but please
Yeah.
No,
maximize.
you don't. I just put it in the chat. Doc's right. Just go over the slide, and over in the right-hand corner, it'll say spotlight. Hit the 3 dots, and you can enter full screen.
Enter full
Cool.
screen. Yeah. Okay.
Cool. Thank you.
Sorry about that. Okay. I hope that helps everybody. We're still working out on this platform here. So
Yeah, but so far I like the platform. It seems like it's working for me.
Yeah.
Okay, so this was a 2018 study, as I mentioned, ketamine versus placebo in addition to sertraline. And what happened here was over 6 weeks, you can see that the depression score went down faster and more in the group that received the ketamine compared to placebo. But it's not a big difference. Look, I mean, all the patients in the study did pretty well, right? Over 6 weeks, their depression scores were cut in half. Ketamine with the sertraline worked faster than placebo with the sertraline. But when you actually get into the details, there's quite a big difference. This chart doesn't make it look like it. And I know the text here is small, so I'll share it with you. The percent of early responder or early improvers in the ketamine group was 85% versus only 42% in the group that got sertraline alone. So in terms of the speed of the response, that's important. The percent of responders at week 6 was 85% in the ketamine group versus 57% in the placebo group. So another big difference. And by responders, they were talking, there was some threshold cutoff on this Hamilton Depression Rating Score in terms of a clinically relevant response. And then the percent of remitters in the ketamine group, which meant, wait, do I have that here? Yeah, no, I don't. The percent of the remitters in the ketamine group, which I think was like a full response, like they didn't even qualify as having depression anymore, was 22% versus 15% in the placebo group, but that was not statistically significant. So then the last thing I wanted to show was the adverse effects, right? Like, did this 50 milligram of ketamine capsule make them have more side effects than just the sertraline alone? And the answer is no. There was no statistically significant difference in the adverse effect profile. Give someone sertraline plus placebo or give them sertraline plus 50 milligrams of ketamine, you're going to see the same adverse effect profile. That's pretty impressive. It shifted around a little bit, like more, a little more blurred vision in the ketamine group, a little more abdominal symptoms in the placebo group, but essentially the same here, not statistically significantly different. So that's 50 milligrams. I showed you what 10 milligrams does. That's 50 in a capsule. The 10 was sublingual. Here's another study from 2018 looking at 37 patients with PTSD treated with oral ketamine. And it was a retrospective review of their hospital admissions prior to and after starting ketamine treatment. The way they were treated was by body weight, 0.5 milligram per kilogram. That's pretty common oral starting dose. So, you guys can imagine some of you may be around 70 kilograms. That'd be like 35 milligram oral dose. Was titrated up by 20 to 50% at each subsequent treatment. Titration was deemed complete when the patient started to feel the psychoactive effects, basically. This is not a full psychedelic experience. This is a glass of wine feeling. That's how they put it in the paper. But my patients don't like that analogy. It's not so much like a glass of wine. It's more like waking up from a dream. It's a light, floaty, pleasant feeling. And the final doses range from 0.5 to 7 milligrams per kilogram. So some people needed a lot more. And of course, there's that pharmacokinetic genetic variability.
Hey, Dustin, these were at the actual VA hospitals?
I don't think so. I'm not sure.
Okay, just curious. Thank you.
Yeah, this was, no, I don't think it was.
You think it was done at home?
No, this was,
hospitals,
So
regular
yeah,
hospitals.
I believe that this was administered in the outpatient setting
Got you.
to
Okay.
so it was actually administered to the patient. So what they did with this study was that for each individual case, they looked retrospectively at how many hospital admissions, and then prospectively, like after they started the ketamine, at how many hospital admissions, and they made the time period the same for both of these. So not every patient had the same time frame, but if you look at inpatient hospital days before and after ketamine, you can see that some people had a lot before and went way down. So over here is the average. It looks like, the average inpatient, the average change in inpatient hospital days was pretty big for this. And you can see most people trended down. There's like one line here that's maybe two that's trending up. And then also, if you just look at number of hospital admissions, I mean, look at this. Some people had like 19, hospital admissions before, and whatever time period that was that they had before ketamine compared to after, quite a bit less. So again, this is a low oral dose. This is administered. What was it? Three times a week. Sorry, my slides are changing kind of slowly here. No, I think I didn't put it on the slide, but I think this was daily, every day. Patients did not develop tolerance to ketamine despite the lengthy treatment period. And there was a decrease in the amount of the drug needed over time to be therapeutically effective. And so this would be their dosage over time. You can see the dosage trending downwards over time. So, and this was a comparison, not the initial dosage, but a comparison at 3 months versus the endpoint of the study. So I like this study for a couple reasons. Titrating to an individual's level of comfort with the psychoactive effects is what I've done with most of my patients, and it works very well. You let them tiptoe into ketamine starting at a low dose that they barely feel or don't feel at all. And then, and I'll tell you more about how I instruct the patients to do this. But once they reach this psychoactive effect that's comfortable for them, it's enough to get their attention, to pull them out of their day and make them have a good hour of a meditation. But it's not so effective that they feel like they need a trip sitter with them. They could get up and answer the door if they needed to. That's really a sweet spot. It's not the only way to use ketamine, but that's one nice way to do it. And the adverse effects, most common, were lightheadedness, sedation, and mild dissociative effects, which is what they were titrating to achieve. They subsided within an hour. That's very common for ketamine, rarely lasts longer than an hour. There was some blood pressure changes, some nausea and headache infrequently, and also short-lived, didn't require any intervention to reduce those side effects. Here's another study from 2019. This was repeated oral ketamine for outpatient treatment of resistant depression. 41 people treated at 1 milligram per kilogram versus placebo 3 times weekly for 3 weeks. So, for someone my size, this would be, about 75, 80 milligrams of ketamine 3 times weekly over 3 weeks, just added on to their other medications. Here's what happened in the short term. You can see that compared to placebo, you get this very rapid improvement in their depression scores, but then it stays improved over the course of 21 days. So this is 3 times weekly. A nice, simple study design showing that it works. Placebo works fairly well too, but it gets kind of ineffective after some treatment there. The response in this study was defined as a greater than 50% reduction in their depression scores, and remission was defined as a total score of less than 10. And so you can see in the ketamine group, there was a 27% remission rate versus a zero remissions in placebo group. Response was 32% in the ketamine group versus 6% in placebo. So based on this study, just using this method, which I get it, in placebo-controlled studies, it's easier not to do individual titration. But so if you just use a cookie cutter method, 1 milligram per kilogram 3 times a week for 3 weeks, your number needed to treat for response or remission is both about 3.7 or 3.8. So that means you treat 4 people, you're going to get one a lot better. And if I think you use a more personalized approach, you're going to end up doing a lot better than that. Not going to keep going on and on, but I just want to give a little bit more here. This was a small one, 7 patients treated with treatment-resistant depression and anxiety, no control group, not a placebo-controlled study, just open label, treated daily for 4 days, starting at 60 and gradually increasing to 240 milligrams, so a little higher than the dosage range in the previous studies. So this was a very short study. This just came out in May of 2020. And what you can see here, on average, the anxiety score went down, by more than 50% within those 4 days. The fear questioning score went down also quite a lot, maybe not quite as much, and so did the depression score, went down quite a bit there. And what they found, they compare this to some of the data on subcutaneous administration of ketamine, and they found that this was about half as fast. So with SQ, you could get these kind of results in 24 hours. With oral, you could get these kind of results in 48 hours. In my opinion, both are very fast. So here are the results in terms of their blood levels of ketamine and norketamine, which I thought was interesting. You can see, again, this is oral, so you're not going to see a lot of ketamine in the blood. And these little jagged lines here are because they would take the blood before and then 2 hours after the person swallowed the ketamine. And so you can see ketamine just bumped up a little bit afterwards, and then it would come down. And you didn't really get this trend of escalation of the ketamine content of the blood. They were taking it just once daily. But you did see some of the stacking of the norketamine, which has a much longer half-life. And if you're taking ketamine daily, that can certainly build up in the system. And then what they're showing over here is the norketamine to ketamine ratio, and that went up over time, again, because norketamine has a longer half-life. Now this is some pretty good dosing here, right? This was up to 240 milligrams per dose. They kept going up until the person said, that's enough, I don't want to go up anymore, over 4 days. And so there was no changes in peripheral BDNF, but that's not surprising because BDNF is not a marker that you can really follow peripherally. No change in blood pressure or heart rate at any dose. So yeah, people are concerned about this. It can happen. Intramuscular, you're looking at a max of 10 beats per minute, or 10, not a max, but like an average of 10 beats per minute, or 10 points on the blood pressure of millimeters of mercury. We're not talking about huge increases in heart rate or blood pressure, even with intramuscular. And certainly you're not talking about big ones with oral, if any. If somebody can tolerate ketamine, if somebody can tolerate exercise, if they can walk up a couple flights of stairs and they're not so cardiovascularly unstable that they can handle that activity, they can handle lying down and taking a ketamine lozenge. I promise you. It's if they have an uncontrolled arrhythmia or there's something else that's sensitive about their cardiovascular system, you might think twice. You might send them for an EKG or make sure that they're rate controlled and things like that before using ketamine. But it's not very common to have adverse effects. I guess while we're talking about cardiovascular effects, I will mention that there are some people that have dysautonomia. I've had 2 in my practice right now. It's kind of like the COVID vaccine reaction, mast cell activation, neuropathic pain picture. I've had 2 patients that have had prolonged adverse cardiovascular effects where they're feeling like there's palpitations or something after a single dose of ketamine, and that can last a whole day. I've heard it twice. So it's these adverse effects are never going to happen, but that those are very sensitive patients. So this was a recent paper from November of last year that looked at 79 people with a broad range of chronic pain diagnoses. So now we're kind of switching from psychiatric to pain. These people were treated with oral ketamine for up to 12 years, predominantly female. There was a lot of fibromyalgia in this cohort, also peripheral neuropathy. 60% of them were on opioids. 16% had complex regional pain syndrome. These are procedures that these patients had been through before. So 42% of them had had nerve blocks, about a quarter had had a spinal cord stimulator, and then you can see a bunch had Botox and so forth. That's percentage. So what happened in terms of pain and quality of life and difficulty with activities and their depression scores. Again, these were pain patients, but they measured depression scores. And so you can see the average pre-ketamine and post-ketamine here. So the pain score, this was a 1 to 10 analog scale, went from 8.8 down to 5. Quality of life improved quite a bit. Difficulty with activities of daily living improved, and so did their depression scores improved. And these were all statistically significant. And over here, you can see the percentage change, pretty big. Quality of life, 62% increase. Visual analog pain scale, 41% decrease. I'd say that's significant. And the average daily dose was 194 milligrams. So they were drinking this stuff every day. Average was 194. Average duration of treatment was 22 months, so quite a long time. Look at these adverse effects. 30% of them had 0 adverse effects. 10% had some memory impairments. You know, 1 person had a negative effect on mood. 9 had some nausea or vomiting. You know, 16 had some drowsiness. Not much for adverse effects, even at these doses, 194 milligrams. So I really want to emphasize that this is in the literature. I've seen it in my practice. People do very well with this. It doesn't cause a lot of adverse effects. And then what did I do? I went back to depression. Sorry, this is a little out of order, and maybe you guys have seen enough of this. I'm going to go past this one. So this is one little study. It's not about oral ketamine, but I think it explains something interesting about ketamine. This was a novel, brief, fully automated intervention to extend the antidepressant effect of a single ketamine infusion. What they basically did was they gave a bunch of people, I forget how many, who had a ketamine infusion, one of 2 computer programs that would interact with them, ask them questions and stuff. And one of the computer programs gave them a bunch of smiley faces and other types of reinforcement like that, and the other one didn't. And so what they did was they had 3 groups. They had a saline infusion with the smiley face program. That's the red line here. On the y-axis, you're looking at depression scores. Then they gave the ketamine with the regular program. That's the orange. Or they gave the ketamine with the smiley face program, which is the green. And you can see the ketamine in both programs performed similarly up to day 15 after the infusion. So the first 2 weeks, they were very similar. But in the last 2 weeks, the smiley faces actually enhanced the response. It prevented this loss of response, just having a computer give them some smiley faces. Now, if a computer giving them smiley faces can extend the duration of the antidepressant effects of a ketamine infusion, what can some of the other resources in someone's life do? Like, you know, if they have a community, if they have a therapeutic relationship with their provider or their provider staff. I mean, there's so much that we can do, I think, to enhance the efficacy of ketamine in whatever form we use it. And this just shows what you can do in a simpler intervention. I think humanistically, we can do much better. So adverse effects, you know, the dissociation. Some people do get anxious with ketamine. It's kind of paradoxical. Nausea is pretty common, but it's more of an motion sickness. So while they're experiencing the psychoactive effects, they want to keep their head still and their eyes closed. I usually recommend people use an eye mask. A little bit of increase in blood pressure, headache. These are all the potential adverse effects. Abuse liability. So let's talk about abuse liability. Ketamine doesn't cause physical withdrawal symptoms, but I have seen people become fixated on it. And interestingly, being a ketamine prescriber, I've had probably about a dozen people who are, in my opinion, addicted to ketamine come into the practice because they're seeking harm reduction with legal source of ketamine and medical supervision instead of what's on the street. Everybody's scared of fentanyl and their ketamine and other things like that. So I believe that ketamine addiction is possible. In terms of patients who have initiated ketamine therapy on that have misused the substance, less than 1%. You know, I can count them on one hand. And you know, these are people that typically have trouble with substances or OCD types that become fixated on things. Let's talk about the urologic adverse effects. The ketamine metabolites are water soluble, 90% are excreted in the urine, and they create crystals, more so when the person is dehydrated. These crystals are uh, injurious to the bladder and the urethra, and can cause ulcerative cystitis with small bladder capacity. The bladder biopsies in 2 of these cases reported in this study confirmed extensive ulcerations and squamous metaplasia, so maybe even promoting, transition to cancer eventually if they keep going. Some of the findings were considered irreversible, and nobody receiving less than 600 milligrams per day had any of these. So this is all much higher doses than anything we've been talking about so far in this presentation. So here's a survey of ketamine abusers, so-called ketamine abusers, over 1,000 men, average age of 22. A lot of ketamine. This is grams per day, so like 2.2 grams per day, maybe up to 4 or 5 grams of ketamine per day. How do they get it all into them? They snort it all day long. That's how. It's a lot. Lower urinary tract symptoms was present in only 6.7% of these people. I would have expected it to be much higher, but surprisingly, erectile dysfunction was higher. So they're complaining less of the cramps. They call them the K cramps, the burning in the urine, but a lot of them don't know that erectile dysfunction is another side effect. So that'll scare them off a little bit if you tell them. Oral dosing, here's the how-to part of the presentation, so the part everybody's been waiting for. 0.5 to 2 milligrams per kilogram is typical, but you might have to go high in some. I usually start every other day or less, then increase to daily if needed, and that's going to be much more often for treating pain than psychiatric symptoms. Most of my psychiatric patients are not taking this every day. They're taking it somewhere between 1 and 3 times weekly. And the caution around mania, we talked about. Psychosis would be a contraindication. Not a history of psychosis necessarily. You just got to watch them carefully. And then same thing as caution for substance abuse. So this is usually how I'm starting people. Now, having done this for 5 years and 500 patients, I'm a little versatile, but like as far as a template to use, I'm starting most people at 40, 80, or 160 milligrams in the troche. Why? Because you can cut it into quarters and therefore have a starting dose of either 10, 20, or 40 milligrams, depending on the person's size and how urgent the situation is, how rapidly you want to see results. So very common for me to start people at 20 milligrams every other day. I have them go up in increments until they get a mild to moderate psychoactive effect. So they are laying down, putting on an eye cushion, maybe putting on some relaxing instrumental music. They are having an hour there of a meditation. And then when that meditation starts feeling strong enough for them, that's the dose that they stay at. Now they start observing. How do they feel that day? But especially, how do they feel the day after and the day after that? What I have people do that are responders, so that's how we figure out, are they a responder? Do they feel better, less depression, less pain, whatever it is, in the couple days after this dose? Some people will feel it that same day. Some people don't start to feel it till the next morning. But then I have them wait until the benefits start to diminish before taking their next dose. I like to watch for the offset. I specifically ask them to watch for the offset of the medicinal therapeutic effect before taking their next dose. Most people end up at 60 to 200. That's kind of like the average place, and 1 to 2 times weekly. All sorts of adjuncts. I'll tell you the little story about the ketamine cuddle. I learned this from one of my patients about 2 years ago. Woman in her early 80s with early dementia and depression, a retired psychotherapist. And we had treated her with cannabis. We made a dent in her insomnia, but the depression was still very prominent. I started her on ketamine, and she did really well with it, including an improvement in cognition. She went from not feeling comfortable driving to driving again, which was interesting. I didn't see anything in literature about ketamine for dementia, but of course, with its pro-neuroplastic effects, we should consider it there. But one time, her and her husband, who was about 10 years younger than her, came in, and the husband starts crying, telling me about this time when she took the ketamine and he decided to just hold her for the hour. And during that hour, something happened where he was able to feel this thing in between them that he hadn't felt in a decade. And I started talking to them about it. And it turns out there was an extramarital relationship that they had never fully recovered from. And there was just something in the silence. They weren't talking. They weren't doing anything. He was simply holding her. But I think that this, ability, and a lot of you that are osteopaths that do manipulation, especially the more, cranial type, that each person is a complex a polyrhythmic self-regulating system. But when you bring two complex systems together, the capacity for regulation increases. And that something happened there. This co-regulation between them was profound. So I learned from that. And for people that have partners that they could trust, eventually I start recommending, once we find out if they're a responder, we get their dose and their frequency right, I start recommending that you ask your partner to just hold you for that hour. Don't say anything. Don't try to do therapy. No sexual activity is permitted until afterwards, because you can't really give proper consent on ketamine. But I've had a number of cases where this has been profound. And even when they don't have a partner, just holding your pet during a ketamine session can be helpful. So here's a case of a 60-year-old woman. Yeah, this is the end of the presentation. I know we've been going for an hour. Thanks for your time and attention. I'll just give you a couple quick cases here. Well, then maybe they're not that quick, but we'll get through it in about 10 minutes. 60-year-old woman with depression. I want to get up in the morning and I want to leave the house, look forward to interacting with people, look forward to learning new things, enjoy a new stage of life as kids are out of the house, rather than binge watching TV all day. She was experiencing chronic hopelessness, sadness, loss of interest in activities, anxiety, poor sleep, sometimes excessive sleep, other times self-isolation, difficulty experiencing joy, laughter, or enjoyment. So a lot of anhedonia. CBT and DBT can help me function, but only at a minimal level, she says. Her current depressive symptoms were 8 to 9 out of 10. Currently, when I saw her, sleeping 5 to 6 hours a night, poor diet, not enough energy to exercise. She was diagnosed with major depression at age 18, had tried various antidepressants with diminishing success. They all seem to either not work at all, or if initially effective, the positive effects diminish over time. She tried mood stabilizers, antipsychotics, anticonvulsant stimulants, and an array of sedatives. Classic case. Trauma history. She had an abusive narcissistic mother. She also had multiple head injuries. Her father died at 16. Clearly remembered her last happy moment. I asked her, when was the last time you felt the happiness? She could tell me right away. It was 3 years ago when I got my 2 baby cats, and they were both curled up in my chest, and I felt so safe and warm. She was on Prozac, Wellbutrin, Ambien, melatonin, and this is hilarious. I had to include it though. Benadryl and Claritin is needed for the cat allergy. I'm sure it was worth it. We got her started on cannabis. She took THC indica blend, 2 milligrams before bed, and 40 milligrams of CBD, which helped with joint pain and anxiety, but did not help with mood. So she's pretty sensitive to cannabis. Started her off on a 40 milligram troche, started at 20 every other day, had her titrate as described earlier. She came back at 8 weeks. She said, I'm so in awe of this drug. I didn't think I would ever feel this good or ever see a world like this. Not feeling this way since she was 18 years old. I can't remember a time I felt this joy, contentment, pleasure in simple things, and not flying off the handle. Her dose was 40 milligrams every 2 to 5 days when I need a little boost. No adverse effects, except it felt like too much wine the first couple doses. Started using her stationary bike at home, purchased a gym membership. I mean, it's pretty, this is a great case, right? This is a profound response. Not everybody gets these kind of results, but a lot of them do. At 12 weeks, she had a recurrence of depression, increased stress. Her daughter was sexually assaulted for the second time. Her husband was less supportive to her because he was having his own issues with a mom with terminal Alzheimer's. The treatment wasn't leading to as much joy, but she describes still being evened out for 2 to 5 days after each session. And she had no improved benefit by going up to 60. I had said, well, try 60. Let's see what happens. Didn't help anymore. So I said, go back to 40. And what I want to say about this case is that she was able to remain stable, right? She didn't crash during this period of increased stress. She kept her stability. And I think it's normal, especially for people with depression, but for anyone, to have a little dip in their mood when stuff like this is going on. I think that's part of our remediating aspect of our mood and emotions to help us maybe change our behavior in our relationships. So I think this was a success that she was able to hang through that tricky period there. Here's another case, more of a pain case, 54-year-old who fell on ice and injured his right arm and shoulder, lost consciousness in 2006. 3 years later, his doctor started him on opioids. Then he got Lyme disease in 2011. When I met him in 2016, he was on methadone 120 plus 75 microgram fentanyl patch, gabapentin 800 4 times daily, Soma 350 4 times daily, and duloxetine 60. Crazy drug regimen there. I mean, God. 4 years later, after starting him on cannabis, we got the methadone down to 15 milligrams and stopped fentanyl. Like, this is a big fast forward, right? But this isn't a cannabis presentation. But imagine how he had to crawl his way out of that hole over 4 years. Gabapentin was reduced to 3 times daily instead of 4. He had stopped the Soma. What was he doing for cannabis? A 1-to-1, about 20 milligrams of each, 3 times daily. Vaping flower for breakthrough pain. He continued to have unprovoked episodes of severe anxiety, depression, and suicidality. Of course, all of these are dangerous, not just to his life with the suicidality, but also to the progress that we've made with the opioid reduction. So finally, in 2020, I started him on ketamine, 20 to 40 milligrams every other day. I've been experiencing a positive lift upon taking the ketamine, often lasting the rest of the day. I do believe that in the intervals between doses, it has helped move my baseline mood as well. No clear benefit on pain. So that was 20 to 40 milligrams every other day. And on the days off, it was still helping him a little bit. And so that was November 2021. Finally, in March of 2020, that was November. I'm all over the place. Where am I? Up and down. So here we are. November 2020 is when we started the ketamine. In March of 2021, he was off opioids altogether. At that point, he was taking ketamine 80 milligrams every 2 to 5 days, so still not daily, with substantial mood benefits, but he didn't really think it was helping him with pain. After getting him off the opioids, I put him on LDN, DLPA, and clonidine as needed to support his endogenous opioids and to help with some of these sympathetic symptoms that were persisting. Maybe they were prolonged methadone withdrawal symptoms. Sleep was 2 to 4 hours per night, interrupted. THC wasn't helping anymore. So we bumped up the ketamine to 160 milligrams taken every night. Now, sometimes, DLPA is phenylalanine. I saw a little bubble pop up there. That's phenylalanine, a precursor to endorphins. Increased ketamine to 160 every night. So what I'll say about ketamine and sleep is that for some people, if you take it too close to bed, it's going to cause really vivid, kind of crazy dreams that could disturb sleep. Other people take ketamine before bed and they sleep great. And that's going to be more of the chronic pain patients. So his sleep improved. He's now getting 4 to 5 hours. Modest improvement in pain overall compared to when he first stopped the methadone. 160 every night or every other night, depending on his pain. He does better with ketamine if he inhales cannabis beforehand. He finds that it enhances the mood and physical benefits. And then most recently, we had tapered gabapentin again, continues ketamine, the average of 5 nights per week. He says, ketamine has been a critical tool for me to help reduce symptoms of many conditions. Sleeplessness, muscle spasms, nerve pain, energy level, and support for emotional wellness have all improved as a result of continued therapeutic use. There are no long-term negative effects that I've encountered so far. And that is all that I've got for you tonight. So let me stop sharing my screen and let's have a chat here. I suspect that I've made some of you feel interested in prescribing this to your patients, but I'd love to answer questions. Let me get rid of this screen share. There we go.
Okay, that was Boffo. I don't know. I don't know how to describe it. That was great.
I stopped hearing you. My speaker turned off. I apologize if anyone was verbal during some part of this presentation because I totally lost sound. Will someone say something now to make sure I've got it again?
um,
Yes, I'm back. I'm back.
you're
Thank
good.
you.
Somebody asked if you could put up the last slide again.
Oh, you mean just my contact information?
Yeah, I guess that's what it was.
Okay, sure. Oh, the one before. Okay, sure. Let's go to.
So
Okay,
yes. Okay, there
that's
we
the
go.
one. All right.
Okay, so while you're doing that, so first question I would have is, I'm a complete novice at this. You know, when John and I were raised, you know, we didn't touch ketamine. That was you know, taboo, along with the CBD and cannabis. You know, we were raised on the what was that movie, John? The Reefer Madness.
Reefer Madness. Yeah.
Yeah.
We
Um,
don't go that far back.
yeah. But so do you have any recommendations for, you know, a more in depth educational program? I mean, you know, this is great. I mean, this is, you know, an overview, but I know personally, I before I would feel comfortable prescribing this, I would want you know, a little bit more you know, knowledge and backing. So, do you have any recommendations for that?
Well, you know, a couple. So first off, you can really crawl, walk, run with this treatment. And, you know, I hope that just by watching this presentation and going yourself to the peer-reviewed literature, and I've got a folder of the low-dose ketamine articles, read them yourselves, look at the adverse effects again. I would suspect that that's enough to start tiptoeing in and giving people 10 milligrams, 20 milligrams here and there, and seeing what happens. That's how I started it. And I was late, right? My mentor, who was Rabbi Nathan Siegel, he told me this again and again for years until I finally listened to him. And I was kicking myself for not doing that earlier. You know, the other answer to that, Bill, is that it's kind of, you know, we kind of can put ketamine in the category of psychedelic medicine, even though it breaks those definitions in many ways. But it's kind of happening in the world of psychedelic medicine. I like this, that it's becoming acknowledged that part of the training includes having an experience with the medicine so that
Mhm.
you can know what you're giving to your patients and know what that experience is like. And so for that reason, I've been holding retreats here at my clinic for up to 8 clinicians who will come in and spend 3 days with me. The first and the last day we do didactics and they see me having patient visits. We do an initial visit and we do some follow-up visits with my patients. And then that middle day, we actually all have a ketamine experience together. It's a ketamine assisted therapy in dyads. We use intramuscular dosing, and it can be a low dose or a high dose, but it's a nice chance just to experience the medicine and get some of those benefits. And then I send people away with a prescription for the ketamine troches for them to use ongoing, you know, at home after the training. So, you know, I'm a rebel, you know, like I'll tell you, I have never attended a ketamine training in my life. I've never, you know, I've started to watch some online that I thought were terrible, so I turned them off. I've never read a book on ketamine. I've just read as many peer-reviewed articles as I possibly can and got my feet wet with patients and gradually developed, you know, some confidence over the years in doing more and more with it.
Sounds like
It's so safe. It is remarkably safe.
Dr. Sulak, how do you feel about interstitial cystitis being a possibility because of the norketamine going in? Is it renally excreted or is it liver?
No, it's renal. It's mostly excreted, about 80% in the urine. And it's you know, if you're at high doses, then it's a real issue. You know, it's interesting because there was some percentage, it was small, but it actually showed up in the Spravato studies where people were using it intranasally and still had some bladder irritation. So I tell people to stay hydrated, and I always ask them if they're having any symptoms. But I've got some of these people now that are snorting like a gram, gram and a half, 2 grams a day, and their bladders are okay. I think it's probably a lot related to consistency of dehydration in the context of ketamine. But that one article that I showed, they didn't have any cases below
Dr.
600
Sulak,
milligrams per day. Yes.
I think you misunderstood my question.
Oh,
I want
sure.
to use it in this interstitial cystitis patient because I
Oh,
think it might have the anesthetic properties
yes.
in the urine.
Got it. Yes. Oh, I forgot to tell you this, though. I would probably not recommend that, because in the biopsies of the bladder tissue with these folks that had the cystitis caused by the ketamine, they saw like a doubling of the density of the nociceptors. The C fibers were increased. So it's like this neurotrophic effect that we want to have happen in the brain. You don't want to have that happen in the bladder. You could actually increase sensitivity to pain. So it's a great idea, and maybe like very infrequently it could break that pain cycle for them. But it would be it's a great question. I would be very cautious to use it with any frequency in someone that's got pre-existing bladder pathology, because you could sensitize them to that.
Well, I've used it a number of times in patients for other indications. On those 12 patients you thought were addicted, do you think it's dependence or actual addiction?
Well, give me some definitions there. What's the syntax you're using? And who's speaking, by the way? I don't see anybody.
It's Dan Freeland. I'm a DO in Austin, Texas.
Okay, thank you, Dan. Oh, I see. It's a little guest thing going.
Yeah,
Okay, yeah,
I didn't give my name in there. Sorry.
that's okay.
No, I do a lot of Suboxone therapy, so I do a lot of addiction, and actually do some pain patients, which I'm going to start using it in pain patients quite frequently, if they're amenable to it. So I've had quite a bit of experience with the troches, and there's been no problems that I've seen. Especially, I start low dose at 10 and do it every day. And I don't have any adverse events or problems with those folks. And but that's mostly with the depression people so far. But I'm going to be using it more in my pain patients now that I know there's a lot of data for it. So thank you.
And there, in all fairness, I didn't include it in the slides. There was a Cochrane review on treating pain with oral ketamine. I don't know, maybe it was 2016 or something. They didn't find that there was any conclusive evidence that was effective. But you know how those systematic reviews go. It's going to work for some patients. So, but yeah, tell me about the definition of addiction versus dependence.
Great question, because it's really hard to tell sometimes. Dependence is when you need it for the condition and you don't have any actual feeling that you need the drug. You just need it for the actual effect.
Mhm.
Addiction is you need it for the either psychedelic effect in this case, or the high, as it were. So in 20% of people, hydrocodone gives them a high the first dose, and that's the one is probably going to get addicted. Not always, but it's just one of those things where it's a good predictor of that. And yeah, I do a lot of addiction because of Suboxone. So
Yeah.
buprenorphine.
Right. And then, part of the addiction definition would also include, like, they know it's having a negative effect on them, but they continue to do it. Correct?
Oh, absolutely.
So,
I'm not going to know the exact addiction definition right
yeah,
now. You
right.
put me on the
But
spot, and I
me neither.
appreciate it.
Right. It's not, as it sounds like generalists and, a diverse group of docs here looking for new things to help our patients. It's probably better for us to define this than to look it up in the DSM. But, what I've seen with some of these individuals who have found me, what happened essentially is that someone that was using a high dose of ketamine came in, started treating him with harm reduction, built a therapeutic relationship, got his ketamine dose to about half of where it was before, in a clean supply that he thought worked better than what he got on the street. He started telling his friends about it. And then, the dealer didn't want to deal anymore. So I got referrals that way, and it's not my area of expertise. Like, I see these people that want to avoid ketamine on the streets. I'm looking for an addiction specialist to join me to help with some of these cases. I look in the literature, and there's very little on ketamine abuse in the literature. And so I think most of the patients that I'm thinking of have anxiety, they have depression, but they're not using ketamine optimally. I mean, I think that we can probably do better than snorting a couple grams a day. I'm trying to stay open-minded to it, but I think that it's probably far from optimal use.
Oh,
And so,
of course. This sounds almost like self-treating ADD or other conditions with alcohol. A lot of people have become alcoholics because they're trying to treat their condition,
for sure.
and become addicted to the effect.
Mm-hmm. Yep. Yeah, and I think that we see that too. And I see people using ketamine as a stimulant. Like, once so by the way, 2 grams a day, 3 grams a day, they are not having psychedelic effects. They miss the psychedelic effects they used to have. There's no way for them to get them anymore. They're mostly using it as like a stimulant. It seems to work that, an anxiolytic and a stimulant is kind of the primary reasons people are doing that, according to them.
Can I throw my 22 cents just
Please.
from the door of mechanism of action? So we see opioid works by stimulating the mu receptors. And when you stimulate the mu receptors, you activate the NMDA receptors, and that leads to calcium influx and oxidative stress. Calcium can cause release of the free radicals from the mitochondria. And that oxidative stress is causing the mu receptors to be insensitive because it will oxidize that mu receptors. And that's where the patient needs more opioids. But more opioids means more of oxidative stress from activation of NMDA receptors, because it does stimulate the mu, but at the same time it activates the NMDA, and NMDA causes oxidative stress, which leads to insensitivity of the mu receptor. So you need more of opioids to get that pain relief, and then that's where the problem with opioids, it does cause oxidative stress in the neurons, and that leads to abnormal neuroplastic changes, and they end up having their neurons being circuits being rigid enough, and the only way and rewarded by the dopamine, because all the circuit it's being tied together, and all their thinking now it's all about how I can seek more of those
Sure.
narcotics so they can satisfy their dopamine circuits, because it's all wired together, the dopaminergics with the neurons in the brain. And so the ketamine, it's like CBD, exactly the same mechanism, but just the ketamine is more potent than CBD. And the ketamine does stimulate those mu receptors, same like CBD, but they inhibit the NMDA receptor. When they inhibit the NMDA receptors, there's no calcium influx, no oxidative stress. Those all mu receptors will be open, and that will increase sensitivity of opioids. And that will lead to the patients to be weaned from narcotics, because they don't need that much of narcotics, because those opioid receptors being opened by the ketamine. Now,
Sorry, just to interrupt real quick, were you saying that CBD stimulates the opioid receptors?
yes, it does stimulate. Well, it stimulates the CBD receptors, and they work like mu receptors. You got my point?
I mean, at very high doses, there's some opioid effects, opioid sparing effects of CBD, but I dispute that. I don't think that
not
there's
direct.
any direct activity of
Yeah, no, not
CBD on
directly.
opioids.
They work on CBD receptors, but the effect is the down effect of the numbness that the CBD does and the mu receptor does is the similar. CBD receptor and mu receptors are having the same synergistic effect in terms of pain relief. You got my point?
Kind of. I mean, there's co-localization of the CB1 and the mu opioid receptors in a lot of the pain areas of the brain, but CBD isn't even much of an I mean, it's not an agonist of CB1. It's actually a neutral antagonist. So maybe what you're thinking of is THC, but then there's a whole lot of other pharmacology in there. But I do get your point about like repeated opioid use and downregulation of the opioid system and the kind of need for dopaminergic stimulation and the attentional fixation on getting more opioids for sure.
Yeah, I'm just saying the CBD and opioid do work on pain relief signaling. That require another lecture, but they have same mechanism in terms of putting the pain down. But what's the difference between opioid and CBD? Is the CBD does inhibit the NMDA receptor like the ketamine does, and the opioid stimulate the NMDA receptors, and that's the leading to oxidative stress. And that's why ketamine will be a good candidate to open up to inhibit the NMDA receptor. At the same time, it does have some receptor activity, so it does work like narcotic, but stimulating, inhibiting the NMDA receptor instead of stimulating it, and that's mean it has an antioxidant effect. And doing that, that's mean you are treating the inflammation, the gliosis with the ketamine, so it does have anti-inflammatory because of all of that effect. So I think ketamine will be a good candidate. If somebody who's on narcotics and you really want to wean them from narcotics and reset the neuroplasticity of the brain and have some anti-inflammatory effect from that is caused by the inflammation that caused by the opioid and oxidative stress is ketamine. The problem with ketamine is long-term use of ketamine does interfere with mitochondrial function. And if you interfere with mitochondrial function, you end up with oxidative stress at the end of the day. Another word with long-term ketamine. And then if you end up with oxidative stress, then you will have the same effect that you have opioid. So what we can do to prevent that from happening is to possibly adding and well, optimizing the health is number one, you know, in general, like what we do integrative medicine.
Sure.
As much as we
Can I interrupt for a second and just comment on the ketamine opioid interaction? You know, because I think it's a great point that I didn't really bring up in the lecture, and I'm not sure about the effect of ketamine on the mitochondria, but I do. What I've seen in opioid using patients who have started on ketamine is a recovery of their sensitivity to the opioids. Like it seems like there can be some reversal of tolerance. It's I don't think that the ketamine is potentiating the opioids because that persists even after the ketamine's out of there. You know, on the days they're not using ketamine, it seems to be a sustained improvement in their sensitivity to opioids. So I do suspect that there's some reversal of tolerance, but also, in addition to that, it's the interruption of their attentional fixation on the opioids, I think is really important, like just getting that disengagement in their patterns of thought and behavior, because as you know, the people who have the most problems with the opioids, it's hard for them to think about or focus on other things. And the ketamine really helps them do that.
Yeah, it will break down the neuroplastic, rigid neuroplastic changes that happen from the opioid, and that they're living inside the circle and it's being rewarded by the opioids, a bit by the dopamine. So that ketamine does break it because it blocks the NMDA receptor. It decreases calcium influx, oxidative stress, and when you provide some sort of relief of the oxidative stress, then those receptors, because they're being blocked by oxidation, it will open up and increase sensitivity of the opioid. Same like what CBD does, but ketamine is more potent than CBD. That's why people, as you said, your patients, CBD and ketamine works together synergistically because they work almost the same, almost similar mechanism in terms of blocking the NMDA receptors. Both they block the NMDA receptors. But to move forward with this, the ketamine does interfere with the mitochondrial function with long-term use. And I think if we add health optimization, which is integrative approach that Dr. William is entertaining all the time, along with maybe some mitochondrial nutrients, along with methylene blue mitochondrial nutrients, that Dr. Mike Beamer has a very nice cocktail of anti-aging and mitochondrial supplement, feeding the mitochondria from all different directions. That may help to reverse any damaging effect of ketamine on the mitochondria. So I'm just giving some solution there for people who are using ketamine if they may be taking some mitochondrial nutrients, which is called X Factor from Dr. Mike Beamer. I think that may help them to even from the dependency of ketamine that will, help to relieve that from happening.
Well, thank you. I need to look more into the impact of ketamine on the mitochondria and whether that's just in the nervous system or elsewhere, but I appreciate you bringing my attention to that. Thank you. Any other questions?
I got a question.
Sure.
Hey, I got 3 quick questions.
Sure.
Do you administer this through troches mainly? Is that your process?
Mainly troches, and we've worked with our compounding pharmacy. I think the base that seems to be the best tolerated is called natatroche, N-A-T-A. It dissolves a little faster, and the ketamine itself can be irritating to the mucosa, though. So the more potent the troche gets, we don't go past 200. It can create some irritation there. But that's going to be my most common starting place is the troche.
And that's through a compounding pharmacist or regular pharmacist?
No, compounding pharmacy, very inexpensive. I think they get a pack of 30 for about $65.
Excellent. And another question was, did you say it is beneficial for neuropathic pain?
Yes, both as a systemic treatment and as a topical treatment. I've seen it, and you know what's so interesting? It seems to improve motor function in some people. I don't know if it's just growing the nerves back. I got a patient who's in his late 30s, a man with a spinal cord injury, who's had drop foot, and now he can start lifting his foot up and wiggling his toes. I got another person that had a lower extremity neuropathy who improved motor function. So it may be doing more than just treating the pain.
That's pretty amazing. And my third question is, are you going to write a book on ketamine?
I don't think so.
Okay.
This whole book writing thing, I mean, I like that the book's out, but it took me forever and it doesn't really pay off. Maybe I'll just have you guys come to Maine and visit me, and I'll give you some ketamine intramuscularly, and we'll call that good. No, I'm just kidding. You know what? I am doing some retrospective research. I got IRB exemption just recently to survey my ketamine using patients and then start collecting their data prospectively. So that's going to be my first contribution to the peer reviewed literature. And then I have a case series of 12 adolescents and children that I've treated with ketamine, which I'll likely also publish at some point.
Thank you, Dustin. Great talk.
You're welcome. And then the rectal, I didn't talk about that at all, but for people that don't do well with the oral route, that want to have that kind of what we're shooting for is the psychoactive effect. Rectal can be putting it in a suppository can be a lot easier. They don't have to hold their saliva, and don't have to deal with the whole thing.
You'll be able to edit your videos.
Thank you, folks. Any other questions or comments? I'm happy to share.
One more, Dustin. So in our town here, there's a bunch of ketamine clinics. They do IV ketamine. It's $2,000. I think they get 4 treatments. Any comments on that at all?
Yeah, I think look, it can look many different ways, right? But like in most of them, they're either using like nearly anesthetic doses, and in some of them, they're just like putting the patient in a room alone. It's like all medicalized. These, I mean, can be effective. Like just as a drug, it can be effective. But I feel like when we start to enter these psychedelic realms with, psychedelic doses of this drug, there's just so much opportunity for human connection. I mean, they don't know what they're missing there. When I get someone on the table here and I'll do an intramuscular session, and it's at 90, we book it for 90 minutes. My hands are on them the whole time. I'm feeling and treating them osteopathically. Afterwards, we talk, they cry, we hug. It's amazing. Like the connection, the therapeutic connection that can be established. And I feel like a lot of these IV clinics, they're just like isolating people and hooking them up to a drug. So I think that it can help. It can help with CRPS, it can help with depression, but there's so much more to get out of it by making that human connection. And then at the same time, they could pay $2,000 for 4 treatments over there, or they could pay $65 for a pack of troches that's going to last them 2 months.
I don't think they know about that around here. So
they don't know. Not yet, Bill, but let me keep nudging you. You keep nudging me on some things too.
Someone's going to have to let them know about that. With that being said, as I hinted to earlier, those clinics around here in Reno, Nevada, they're worried about the rise in blood pressure. And I think it's think it's a myth. I'll just be honest. Have you seen that?
Not much. I mean, I haven't treated anyone with uncontrolled hypertension with ketamine, but I'm not like a stickler. If they're more than 120/80, I'm not going to not prescribe. It's like my screening question is basically, can you handle a couple flights of stairs? Do you have shortness of breath or chest pain? If not, like, you're going to be okay lying there on your back with your eyes closed, taking a ketamine troche.
Especially if you're there, calming us down with your hands.
Or even if they're just at home by themselves, still.
With someone they trust. Got you.
Yeah, or not. I mean, I feel safe treating people that live alone, that don't have a sitter or support, and I'll start them at 10 milligram. Like, unless there's signs of likelihood of misuse, they can tiptoe their way into this so incrementally that they're not going to get in over their heads. If you go up in 10 or 20 milligram increments, if you go over the line, you're not far over the line.
Right. Excellent talk. Thank you.
Hey, I got a quick question, if you can hear me, Dustin. First of all,
yes,
I'm a little bit disappointed that you're not going to write a book on ketamine, because I think I was probably one of the first people to bought your other book.
Oh man, thank you.
And all that kind of stuff. I still read that thing. But my question is, seriously, when we're talking about maybe treating depression or PTSD, maybe specifically, do you have a take on comparing MDMA therapy to psilocybin, to ketamine, to cannabis? I mean, that's such an open question, but I thought if anybody would maybe have an opinion on how these compare, it would be you.
It's a great question. I have much less experience with MDMA than any of the others that you've mentioned, but I do have some close colleagues here in Maine that have worked more with it, and I think that it's possibly the most powerful when it comes to trauma, and also the most resource intensive. These are long psychedelic assisted therapy sessions that typically require at least 2 operators to make them possible.
Yeah, it sounds like psilocybin as well.
Psilocybin is a little more doable. There's so there's microdosing applications for MDMA. I've had people do that before, not a lot, but with psilocybin, I think that it's more amenable to group therapy. It requires a little less one-on-one intervention from the operator of the session. It's 4 hours instead of 6 to 8 hours. It's I think psilocybin therapy often takes care of itself a little bit more. The therapist doesn't have to do a whole lot. Like with the MDMA, there's a lot involved there. A lot of working with transference. You got to be good at that, which is a whole nother thing. So I think the psilocybin is doable, and then certainly as a microdose for antidepressants, psilocybin can be very effective for people. Non-psychoactive. It's not like ketamine where they, most of my ketamine patients, I'm still getting them to a dose where they got to go lay down for an hour. With psilocybin microdosing, that's not the case. They take the dose in the morning and they go right about their day. They might feel a little open-hearted or a little softer or something, but that's it. But then the psilocybin is less compatible with all the SSRIs. They tend to blunt or totally abolish the benefits of the low-dose psilocybin. So in those cases, I'm leaning more towards ketamine. It's also more legal. I mean, there's some quasi-legal routes of access for psilocybin here, joining churches basically. But the ketamine is, I know the pharmacist is giving them what I'm telling them to give. It's consistent. So, and then in terms of cannabis, cannabis is wonderful for PTSD. I think one of its best effects in that condition has to do with sleep that's disturbed by nightmares. It's just such a win all the time for that. But I start with cannabis and I stop with cannabis for a lot of people. But of course, like, there's going to be people that are refractory, and you're just naturally going to attract the tough cases. And I encourage you to consider ketamine in some of those.
Hey, Dr. Quinn, that was a awesome, perception. So with everything you've done, Dustin, it looks like ketamine would be the start for those of us who have traumatic brain injury, PTSD, blah, 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 military. And we know about, MDMA and psilocybin and the whole ibogaine and everything. we still have some fear about doing that whole process. It seems like ketamine would be an entry gate into learning what your heart rate and your own response is going to be to what's going on. And so you could step into those next lines of treatment, correct?
I think it's a nice bridge. Ketamine, has this quality of being pleasant. Like if I had to describe cannabis and ketamine and mushrooms and MDMA, so cannabis, first of all, in terms of its like psychedelic nature, a lot of people don't think about cannabis as a psychedelic, but it absolutely is one, either with a high enough dose or even with a low dose in the right setting. There's a modality called psychedelic somatic integrational psychotherapy, PSIP. I've been trained in it. It's amazing. You give someone a couple hits of cannabis and do the right thing, and they have a full-on somatic reaction, psychedelic-like experience at a very low dose. And by do the right thing, I mean basically tell them to allow the involuntary somatic activity to take over. And cannabis will put them in the front seat of the fucking roller coaster. It's crazy. Ketamine will allow them to be on a cloud above the amusement park, watching the whole thing happen. It typically feels very safe and pleasant. Mushrooms will show you your mortality. They'll show you the dark side. They'll show you that you'll grieve. I mean, they put all sorts of shit up into your face, and it's therapeutic. Ketamine doesn't often do that. It can, but it doesn't often. It's usually a very pleasant experience.
Stepping stone. Sounds like an absolute stepping stone. Kid you not.
Yep. And in that particular modality, ketamine is typically used first before cannabis. It's considered a much more gentle entry, and then you can do a cannabis session. It's basically like a spontaneous cannabis-induced panic attack. It can be incredibly therapeutic when it happens in a relational context, but you got to have some skills to go through that with somebody.
Thank you. Wow.
Thank you. Wow.
Great class.
Well, John, I think we got our next outing. We're going to go visit Dustin.
Yeah, AOSIM convention in Maine. If I was licensed in Las Vegas, I'd be coming out there to do it in your hometown, Bill.
Yeah, you can do it here too. Okay, and a little bit of a summary, Dustin. You got a wrap up for us here.
The wrap up is that this is an inexpensive, powerful tool with a well-characterized safety profile that's been available in the compounding pharmacy for decades. Don't overlook it. Your patients could probably benefit from it, and it's a big disruptor of the pharmaceutical industry, and it just has a lot to offer people. So give it a shot. Be brave. Pick your most suicidal patient and give them 10 or 20 milligrams and see what happens. It's going to be amazing.
There it is, John, right up our alley.
Dustin is the man, as always. Thank you,
Dustin.
Pleasure to work with you guys. Thank you all so much for keeping this torch going and making it happen. It's been a pleasure to share it with you.
Thank you. So next week we have Beth Shirley, who's a pharmacist, and we're going to be talking about some other different aspects about nitric oxide.
Great.
Okay, I will not be here. Joel and Dr. Nario will be hosting. I turned 70 years old on Monday, and I'm going on a cruise.
Nice, Bill. But what's your biological age? Like 52, 53?
At 39, I started counting backwards, so I should be about 18 right now.
Good.
Okay.
Good. Well, congrats. Enjoy your cruise.
Dr. Halassa, if you're still on, Dr. Halassa and I will be in Miami this weekend, speaking at Dr. Farshian's American Academy of Stem Cell Physicians. So we'll be there, and we'll be reporting back. But after that, I'm going next week. So everything's all set, and I want to thank everybody for being here. All of our new people, I see there's a few new names on here. Thank you for coming. We always ask, please bring one person. We've been here, and then we'll double our census. We've been here since October of 2020, in the middle of the pandemic. We've been here every week except one 4th of July we skipped. and we're soldiering on now. We're getting more comfortable with this platform. We've only been on this for the month of January. We're have partnered now with World Health Net and A4M, and so we're doing better. We're doing better and better things. So, thank you all for your presence. Anybody who has anything they'd like to present, please let me know. We are not CME. You can present anything you want. You can use brand names. You can say bad words. Not a few there at the end, Dustin, but that's okay. We'll let that go.
Leave it up, please.
Yeah. And we always put it up on our website. We still have the AOSRD website, aosrd.org/webinars. All of the videos from our previous sessions are on there, except for the ones I messed them up, but that's another story. And they're all on there. I also apparently have a YouTube channel that's sort of grown without even my. I'm not sure exactly how it happened. It's Clearfield Medical Group, and the videos are ending up there also. That's on YouTube. Okay, so if you want the video, any of the videos that from previous, they're there. Like I said, please get in contact with me if you don't know where to find me. At gmail.com. And you'll notice that the email flyers every week will be coming from a different address because apparently Google and Yahoo don't allow you to send them out on the free ones anymore. So I had to use one of the ones that I used them, an old one what we had when I first came to Reno. So it'll be coming from Dr. Bill at rejuvenatereno.com until I figure out another way to go. But
hey, one more question, Doc.
Yeah.
Dustin, I know you just got done, I believe, holding a practitioner in-person, I don't know, a retreat. Are you doing that once a year? Are you doing that twice a year?
I'll probably schedule some for the summertime.
Okay. Do you also?
I don't have the dates yet. I got, what's crazy is I've got a baby coming next month. My fourth child. My youngest is 8. So I'm going to have my hands full for a little bit. My oldest is 14. So we got a big spread here. I'm like starting all over again.
Mm-hmm.
Okay. But so thinking past that has been a little hard for me, but I should be able to schedule a couple more for maybe June or July or maybe even later, like August, and let the mosquitoes die down a little bit. But I'd love to have some of this group come here. We do a maximum of 8 people, and they're really beautiful sessions.
Excellent. Thank you.
Yeah, I'll let you know when I get that firmed up. I'll circulate it to the group. Thanks for asking.
Okay.
All right. Thank you, Bill, so much.
I'm not sure. There's a question here. I'm not sure you answered that. Would you consider treating patients that didn't want to be on antidepressants long term, but weren't necessarily treatment resistant? Did you answer that one? I'm not sure.
No, I didn't. So yeah, no, they don't. For me, they don't have to be treatment resistant to be a good candidate for ketamine. I mean, I've got people that just say flat out, I never want to try an SSRI. I've read that their efficacy is slightly better than placebo and that they cause low libido. There's just no way I'm going to do that. So I, in my practice, I don't need them to have failed a number of therapies. I still often start with cannabis before ketamine because I don't know why. I think it may be a more sustainable, long-term, more beneficial side effects. Maybe I'm just partial to cannabis. I don't know, but it depends probably on the case, the urgency for benefit, but I do not make people fail SSRIs before starting them on ketamine. No way.
Okay, great. Okay. Anybody else? Any comments, questions? I'll be back in a couple of weeks. We'll be reporting on Dr. Farshian's stem cell convention. And like I said, next week, Beth Shirley will be talking about some other aspects. We've had the basics already on nitric oxide. So I'll see you, John. Anything from the medical school?
All's good. All's good.
Okay.
Hey, by the way, Dustin, I found a friend of yours, and she's the chief now of a new medical school is starting, osteopathic, near my home. And the director of family practice is Catherine Figge.
Oh, cool.
So
That's great.
I hope we can talk a little bit about joint efforts in that, because our little group here with AOSIM is trying to do research. And since they're starting a brand new medical school and they're very open-minded, and Catherine Figge is one of the biggies in that game, perhaps
Perfect.
we can speak a little bit and maybe get an exchange going.
That'd be great. And Bill, the intro to nitric oxide, I imagine that's on the website. There's a video I can watch on there.
We had Nathan Bryan, I think, a couple of times, and somebody
Oh
else.
yeah, I saw Nathan do it. I saw that one.
Yeah, I think we had somebody else. I can't remember who. Yeah, there's just go on the website. Just whatever you search, put in a nitric oxide, and it'll pop up.
Perfect.
One of these days, I'll organize it better. So
yeah, I did see Nathan's though. That was a great one.
Okay. All right. Anybody else? Any questions, Dawn? Nice to see you again. New folks, always nice to have new friends. And please don't be a stranger and bring a friend. Okay. All right. Dustin, can't thank you enough. It was great.
You're welcome. Good night, everyone.
Good night, everybody.
Good night.